Okay. You all set, Jocelyn? You ready?
I'm ready.
Well, welcome everybody to Cardiology Grand Rounds. Today we have a very special guest speaker and a very special topic. I've never spoken about this before in Cardiology Grand Rounds. And can you all hear me?
Yes.
Hear you. We hear you.
Me?
Yes.
Welcome everybody to Cardiology Grand Rounds. We have a very simple topic and a very good. You can hear me. The Division of Cardiology has always supported the importance of diversity, equity, and inclusion, but we don't know all of the details and ways that we could even better. So we've decided that we should have a cardiology grounds. We're happy to welcome Dr. Jocelyn Williams, who is Dean for Diversity and Affairs at CMSRU and Associate Professor of OB/GYN at Medical School of University.
Perry, I think you have a bandwidth problem because you're cutting in and out. You might want to turn your video off.
All right, we'll try that. I'll go ahead with the introduction one more time. Okay. So we want to welcome Dr. Jocelyn Mitchell Williams, who is the Associate Dean for Diversity and Community Affairs at CMSRU. Jocelyn received her Bachelor of Science in Electrical Engineering from Rutgers University, where she was the Paul Robeson Scholarship winner, which is very prestigious. She went on to get a PhD in Biomedical Engineering at Rutgers and UMDNJ as part of a consortium between those two universities. And she received her MD degree at UMDNJ Robert Wood Johnson Medical School, where she received the Faculty Award for Outstanding Medical Student. Period. She received her residency in OB/GYN at Cooper and performed her residency, I should say, in OB/GYN at Cooper. And she's currently Associate Professor of OB/GYN at the Medical School and Cooper University. She directs the Pre-Medical Urban Leadership Summer Enrichment Program, or the PULSE program, and so many other programs. She's responsible for the medical school receiving the Spencer Foreman Community Engagement Award in 2019, which is one of the highest awards from the AAMC. And she received the Inspiration Award from the American Medical Association just last year. She is Senior Advisor to Cooper University Healthcare Leadership Team for Diversity, Equity, and Inclusion. And I couldn't think of a better speaker to join us today. And it's also her birthday, so happy birthday, Jocelyn, and welcome. Thank you for joining us.
Thank you so much, and thank you for that very kind introduction. And I'll just ask that if I seem to have the same bandwidth issue as you, that you let me know, and I can certainly turn off my video as well. So I want to again thank Perry Weinstock for inviting me to come and talk to you today about diversity, equity, and inclusion. And that is just a very broad topic and not something that I could possibly cover in an hour. I've kind of truncated to be diversity, equity, and inclusion in medicine, because as many of you know, diversity is very important in all aspects of life, and certainly business organizations have long recognized the value and importance of diversity. Healthcare has been a little bit slower to get to the start gate, but I think we're making great headway now. So I'll try to cover a few topics, and I hope that it provides some insight for you, and I hope to give some direction as to where the medical school and the healthcare system are going in terms of diversity, equity, and inclusion efforts. I will say, for disclosures, I have no financial disclosures. And that while I am the sort of senior person for diversity, equity, inclusion at the medical school, and one of my roles is to be an educator, I do consider myself a learner in this arena. And I try to make it a habit of every day trying to read, listen, or engage in something that helps improve my diversity, equity, and inclusion knowledge. So why does DEI matter? What is the big to do about all of this? And I will say that probably for medicine, one of the biggest issues that we need to face as professionals is that we are now, the demographics of our country are changing greatly. New Jersey is one of the most diverse states in the nation, and we as physicians need to be able to take care of a wide range of patients from various socioeconomic statuses, from different cultures and different ethnic backgrounds. And as we have seen, especially during this year, in the year of COVID, that there are significant health disparities that exist, especially for some of our minoritized populations. And as we see, with increase in healthcare coverage for individuals with Affordable Care Act in place, we have more and more patients that need to be taken care of. There's a physician shortage that's only looking to get worse in the future. So why not now really pay attention to how we can use diversity to our advantage to take care of these populations that we do see these significant disparities in, and in these underserved communities in medicine. So my goal today is that we are able to highlight some disparities that exist in healthcare and some of the outcomes, and provide a better understanding of the impact of diversity. I hope to erase some of the ways that our personal, our professional, and even our workplace environments contribute to the disparities that individuals and populations experience. And then obviously to try to address some of these disparities in care. What ways can we strategize to improve these things, and to kind of describe ways of creating a more diverse and inclusive environment, not only for our patients, but for our colleagues as well. So I want to turn to this report by the Institute of Medicine. This is really where a lot of the robust data around health disparities came from. And it was the strong work of about a 15-member committee that spent over a year really looking at health disparities. They engaged in significant literature research, they commissioned papers, they did workshops, they interviewed people, had roundtable discussions, and so forth. And their charge of this committee was really to be able to assess, evaluate, and provide. So to assess the extent at which the racial and ethnic differences in quality in healthcare existed, to evaluate what some of the sources of these disparities were, and then to come up with some recommendations that we as healthcare providers could use to try to minimize or get rid of these health disparities. And in looking across multiple different fields, multiple different medical conditions, one of the main findings from this committee was really that that even when you normalized for things like socioeconomic status, for insurance, age, same sort of disease progression, what they found was that racial and ethnic disparities continued to exist. And obviously in those minoritized populations, the death rates were significantly higher. Now, this is just a chart specifically of cancer incidence and cancer deaths. And around the time of this report is 2003, and you can see that there's significant disparities that exist for incidence of disease, and a much larger disparity for the death rates in certain minoritized populations. And here we're looking at men, and the red line is specifically for Black males. Now, over time, after this report and after some of the suggestions from the committee, we see that the rates have decreased and have come closer together, but still for this minoritized group, the rates are still significantly increased. One of the things that they also found in this year-long study was that racial and ethnic minorities were more likely than white patients to refuse treatment. But these refusal rates are really small. And I think that's important for us to pay attention to, because we often see patients being blamed for their disease state. We want to often say, well, it's because they're declining treatment or they're refusing treatment. And when you look at these in broad numbers, you really realize that those numbers are small. So while it may contribute, it is certainly not the main reason that we see these great disparities. Social determinants of health certainly play a role, things like education, income, housing, access to food. Those all are patient-related issues that can play a role. But when you also do a deep dive on that, you realize that many of these things are because of the structural racism that has been put in place. So again, can't do the victim blaming in these instances. It's up to us, as physician leaders, to be advocates for our patients and to really push for some policy change that can help improve these kinds of situations. The other item was health systems. So obviously access to healthcare can play a significant role in disparities where people are geographically, whether they have insurance. Again, the insurance issue being less of an issue now as we're in the day of more affordable healthcare. And then the last item on this list was the practitioner. How does the practitioner contribute to these disparities that we see in these patient populations? And through this, again, year-long investigation, there was noted to be significant stereotyping, clinical uncertainty for some physicians in how to take care of certain individuals, and then bias played a significant role. So I do want to just take a moment to talk about bias, because for the physicians in the room, I'm sure you are aware that you were recently required to do the Harvard Implicit Association test and to also complete a module from the University of Washington on implicit bias. And for those not familiar with, I just want to go over briefly what implicit bias is. And these are really unconscious perceptions that can influence our understanding of things, our actions, and our decisions. And there are things that they're essentially out of our control. We're not necessarily thinking about these things. They bubble up and we don't actually sometimes realize that we are thinking in a certain way that can impact somebody's care or how we are perceived by different individuals. And when we hear the word bias, we sometimes always associate some negative connotation to it. But really, bias can have both favorable and unfavorable thoughts. But sometimes, even if it's a favorable thought, it can lead to a disparity for another population. So we do have to be aware of these things. But I do want to just say that it is a normal process. It's not anything that we should be ashamed of, and that we should all recognize that we do indeed have bias. I have bias. And so I will pose the question to all of you is, what is your bias? And I'll just pause. I don't expect for anyone to speak up and say what their bias is. Often people don't want to admit what their bias is openly or even in a chat box kind of function. But, and I think sometimes because when they hear the word bias, it always immediately goes to race, and people think that by admitting their bias, they may be perceived as being a racist. And that is certainly not the case. So one of the purposes for the implicit association test was for physicians to be able to get a sneak peek, perhaps, of what their biases are that maybe they didn't realize, and to have an opportunity to reflect on them. So for those of you who hadn't done the Harvard Implicit Association test, I highly recommend that you do it. It's free, it's online, it's easy to access. You don't have to put in any personal information of who you are. So how do you feel when someone asks you that question? What is your bias? Are you someone who says, oh, I don't have bias, I treat everyone the same, or I don't see color when I interact with people? These are some of the common phrases that I've often heard over my years working in diversity. Or are you someone like me who can say, I realize I have bias and I realize I have some work to do. Now, Sigmund Freud likened the conscious and unconscious mind to an iceberg, where what you see above the water is what's visible, how you project. So more of those explicit biases that you may have, some of the things that you may be seeing in some of the hate violence that's going on today, that's conscious bias. But what we see in the iceberg below is more our unconscious mind. It's more about the core of who we are. And these core values that we have are these learned ideas of what is good and bad, what's right and wrong, acceptable, unacceptable, and so forth. And how we, and our interpretations of this are how we feel those core values should be reflected when we're in specific situations in daily life, whether that's at work, whether we're during socializing. And all of these core values are influenced by these formative factors that we begin to experience from the moment we're born. Influences from our family, influences from church, from different economic situations, and more, especially today, what our children experience is influence from the media. So we all have and hold these unconscious beliefs about various social groups and identities. And that's okay. Our unconscious thoughts, though, can influence how we view people. Imagine for a minute you're walking into a room with a bunch of people who you've never met for the first time, whether it's you're at a cardiology conference or you're a medical student walking into orientation for the first time. You walk around the room, you kind of start to begin to size people up. Same thing happens when you're walking down the street alone and you start to assess people as they approach you. And this is something that our body does. It's kind of part of a defense mechanism, some part of that fight or flight system that can be activated. It allows us to quickly process things for survival, right? Millions of things are being pushed to us at a time, but we can't process all of that. So we have to begin to categorize. And the problem with that is that sometimes we can categorize people too quickly and make unfair assumptions about them. And this can happen in our everyday life. It can happen even when we're taking care of patients, especially if we're in a busy emergency room and things are happening very quickly. Sometimes we kick into that categorization mode. So how does bias play out in some of our day-to-day life? Well, if you're an obese child, your teacher might view you as someone who is less intelligent than a slim child. And this is work that comes from a lot of psychology studies. If you're a Black student, you're more likely to be punished than a white student for behaving the same way in the classroom. And if you have a white sounding name, you have a better chance of getting a call back for a job interview. And this was work that was done, an interesting study that was done where they presented resumes that were identical, but those resumes had different names. And so on some of those resumes, they had the names Emily and Greg, and on others, they had Lakeisha and Jamal. And the end result was that if your name was Emily or Greg, you got a call back for an interview 50% more often than Lakeisha and Jamal. And again, there's no difference in those interviews. It were in the resumes. So those examples might not mean much to you if you're not in those marginalized groups, right? But I would argue that, these everyday occurrences, yes, they don't affect our roles as physicians, but these might be our children that are obese. This might be my child who is Black, right? So we have to think about those things, and us if we are a woman applying for a job over a male. So let's go to something that may be a little closer to home, something for faculty members or a clinical employee. Female physicians are 20 to 29% less, make 20 to 29% less than their male counterparts. Again, these are studies that have been done where people have equal qualifications, equal experience, but they're offered less. So here's the whole part about female physician equity. Where does that come from? And maybe there is something to say with the lack of some negotiating skills, but it's not all of that. Some of it has to do with bias. And what about when you're ready to go up for promotion or you're applying for a new job? Well, letters of recommendation have also been studied. And what was noticed in these letter recommendations is that letters for men are often longer. They have more words in them. And some of the words used are very different. They have more standout adjectives. So Dr. Weinstock might be this charismatic leader, where I might be described as somebody who's a good team player. There may be more of those words, excellent. Women's letters tended to have more doubt raisers. So while they were positive comments about ability to multitask, it might be something like, she has the ability to do many tasks at one time, this all while raising a large family, which then puts some doubt into the employer's mind about whether they want to hire that person. Women also tended to be more described for their teaching, where men were described more for their ability to perform outstanding research. And what about you if you are a minoritized female, a woman of color, and you are rejected by a flight attendant who is actually seeking an actual physician? So imagine you're on a plane, there's a call for help because a passenger is in acute distress, having heart symptoms. You raise your hand or turn on your light, and you're passed over by the attendant. This goes on a couple of more times before you stand up, but you are then still rejected by the flight attendant. And this is all because of bias. This is because this particular physician, this was rejected because she didn't look like what a physician should look like. And that was, of course, the Delta Airlines debacle. So what about bias in the clinical environment? Is this something that happens? Is it something that we do? Obviously it does, because I'm talking about it today, and it was one of the findings of the Institute of Medicine, but it's something that we don't inherently want to believe, right? We go into this profession to be noble, to take care, to do no harm, but these things do exist. These are just a few highlights of some areas that do face significant disparity. And one is around the issue of pain. And this is one of the things that's been studied over and over again, and that Black individuals receive less pain medication than white individuals. And this is studied over many different disease processes and over male versus female, and even children. And even in children, they found that those Black children were less likely to receive the same amounts of pain medication as a white child. Another area that's suffers significant disparity is the LGBT population. And specifically, the transgender community has faced tremendous disparity over the years, and especially when you now add intersectionality to that, it shows evidence of further disparity. In the center here, I talk about, or I have this article about a women's cry, and this has to do with the morbidity and mortality rates among Black women in our country, which is well over what it should be for white women. And this has become a particular focus of late. In fact, this week is now being recognized as the Black Women Morbidity and Mortality Awareness Week. In terms of the pain in that particular article, the interesting finding about this was it didn't just have to do with delivering the amount of pain medicine that was delivered, but about the false beliefs that the physicians had about Black people in general, and that there was a belief that Black individuals felt pain less than their white counterparts, which is quite frankly absurd. And in the article again about the Black women in our country, Black women are 3 to 4 times more likely to die from a pregnancy-related cause. And even more disturbing is that in New Jersey, it's 7 times the rate. Now, the First Lady of New Jersey has made this particular issue one of her things that in her mind she wants to address head on, and has made a commitment to try to reduce this disparity by 50% over the next 5 years. And I certainly hope that happens. You know, as a Black woman, and as a Black woman who currently has a daughter who is 39 weeks pregnant, this is something that keeps me awake at night. You know, it's scary. And that's even being an OBGYN. I fear for her, even though I know my colleagues will take great care of her. And then for the transgender community, what's really disturbing is that 1 in 5 are just not allowed outright care. And that's more an example of explicit bias, but it's something that we should not be tolerating. So this is a model that's just been generated by some of our social scientists about how this implicit bias in the provider can play out into disparities in healthcare. And there's a couple of paths. You can either make some judgments and decisions about patient care based on your implicit bias without sort of knowing it. But more often, there's also these issues with bias in our communication with patients. And even though you might not be aware of your implicit bias, studies have shown that patients can kind of pick up on that. And although I'm not going into those studies today, that Harvard implicit bias test that I was talking about, there have been numerous studies where the provider has taken this test prior to encounters with patients. And then after the encounter has happened, they've been rated by the patients, and they noted that the rates of physicians who had high implicit bias had lower patient satisfaction scores. So the patients kind of pick up on this. So what about the field of cardiology? It's a talk to a cardiology group. So I do want to spend some time talking about disparities in the field of cardiology. And I'll go back to a phrase that I mentioned before, and that's that implicit bias is at the heart of disparities in medicine. And unfortunately, many of those disparities do exist in cardiovascular medicine. I know that I'm speaking to the choir when I say that heart disease is one of the #1 killers of people in our country. I do want to say out loud that it continues to be the that African Americans continue to have worst outcomes in terms of survival. There were probably over 200 articles written on disparities in myocardial infarctions between a 20-year period. Yet when there was a study done that surveyed cardiologists, only 33% of them felt that disparities existed in the field of cardiology, and only about 5% thought that there was any significant disparity in care in the practices that they worked in. So I want to just focus on 4 different areas of cardiovascular care, and these were investigated, a literature search done and investigated by Capers, who is a cardiologist, but also an expert in diversity, equity, and inclusion. And so I'm going to go through each of these and just show some of the brief summaries of some of the research that's been done in these areas and disparities that are thought to be caused by bias. And that's because, again, they've been normalized for age, for race, or for socioeconomic status and so forth. So with the automatic implantable cardioverter defibrillators, in this study by Groenveld, he looked at patients who demonstrated the need for them, and what was found was that Black patients were less likely to receive these implants at about half the rate. And so without this in place, there was a subsequent decrease in their survival. He later did a similar study in patients that were veterans, and this was 50,000 veterans surveyed that lived in a Veterans Affairs medical facility, and they were less likely to get prophylactic devices compared to their white counterparts that were at similar medical facilities. Even when there was particular attention to following guidelines in this American Heart Association program, Get With The Guidelines program, patients had to meet the criteria of having the ejection fraction less than 30%. In this study, Black females were 28.2% likely to get the device, whereas white men were 43% likely to get the device. So this is, again, an odds ratio of 0.54, with them getting it much more significantly. Black males also received it at about a 33% rate, so got it more than Black women, but there was a significant disparity seen for women. And this is a theme that kind of plays through the cardiology field with women as well. And then to look at interactions, or how well a patient might listen to recommendations, physician versus using a video decision aid. Patients were randomized to either watching a video that had a multi-team discipline kind of direction at helping a patient realize the risks and benefits of the procedure, versus having a cardiologist provide the information. And they did see a decreased disparity when there was a multi-team approach providing the patient with the information. For resynchronization therapy, similar results were found. In this 4-year study, there were patients that were increasingly enrolled for use of this therapy for all different ethnicities, but when you broke it down by race, there was a significant disparity for Blacks more than Hispanics. And then in looking at patients who had an AICD in place already, but also met criteria for the resynchronization therapy, again, when they looked at racial disparities and also looked at out of guideline use, out of the 22,000 patients that were evaluated in this study, the odds ratio was 0.84 for Blacks and 0.83 for Hispanics. And then for our refusion therapy for acute MI, again, some studies with a large number of patients. The Black patients in this particular study did have the ST segment elevation for acute myocardial infarction. They were eligible for the thrombolytic reperfusion therapy, but 47% of them didn't get any therapy at all. And in this group, there were 55% that were over the age of 70, and 2/3 of them received no therapy. In, again, a study where they're looking at male veterans hospitalized for MI, the Black patients were less likely to have major coronary procedures done within 90 days following the event. They were less likely to have cardiac catheterization, percutaneous coronary intervention, or coronary bypass surgery. And these percentages just increase for each of these particular interventions. And then the final area that I'll look at in terms of cardiovascular care is the mechanical revascularization procedures for peripheral artery disease. And, this is something that is really scary for Black people, right? The thought of having to have an amputation. And most of these studies showed that there was an increased rate of amputation in Black individuals. They were more likely to get amputations versus their white counterparts, who were 2 times more likely to have the balloon angioplasty or the stent placement, or be referred for the bypass surgery. And in this study by Islami, 2/3 of the patient with the lower leg ischemia had surgical invasive procedures, with 37% of them having amputations. And in that 37%, more of them were Black or patients with lower socioeconomic status. These disparities aren't unique to our country. In England, similar studies have been done. And in the particular study by Ahmed, it was shown that there was a 2.4 times rate of amputation for Black women versus white women. And then the final study here was of over 775,000 people in a database, where they looked at, does access and resources make a difference? And again, the amputation rates were higher for Black versus white. And in this case, when they're looking at locations, it wasn't that the hospitals didn't have resources. In fact, the hospitals with the most resources had more of these disparities, so more people having the amputations. And so what most of these studies essentially show is that Black individuals are less likely to have the same cardiac care by about half the rate of over their white counterparts. And it may seem that I'm, seem to be focusing more on the Black and the white, but that is unfortunately where most of this disparity work has been done. So, I hope that over that past 10 minutes of going through those particular studies, that I've given enough evidence to support the need for equity. And providing equal care does not necessarily result in equity. So there's an assumption that everyone benefits from the same supports, as illustrated in this diagram. Many of you have probably seen similar depictions of this equality, equity, and justice image. But you can't just give everyone the same support and expect the same outcome. You do need to do some individualized care to make sure that we are that people are able to have equity in care. And that may be equity in care for, in some instances in the work that I do, it's about equity in education. So there's all kinds of twists that you can put on this. And the bottom line is that we want to make sure that we can break down all of the systemic barriers that exist so that we don't need to worry about the types of support that we have, that everybody has equal opportunity to get the care that they need. So going back to some of these recommendations now that the Institute of Medicine suggested based on their findings, much of this is in work. Much of this needs to have continued work. We have some of these things in play at our health system, but it's not always utilized to the best of its ability. So the first is obvious, right? Consistency and equity of care through the use of evidence-based guidelines. So trying to stick with those guidelines as we can so that we're making sure that we're not giving desperate care to individuals who deserve our appropriate treatment. There's some recommendations in terms of payment of systems, making sure that we have adequate supply of services to our minority populations, and really providing incentives for having positive outcomes. So incentives for reducing disparities. Instead of always worrying about how many patients do we see, let's get rewarded for making sure that there's not disparities existing. Language interpretation services, this is something that we have in place, but there are disparities that exist. They're not utilized as they should be. And I see this time and time again, even when we're taking care of patients in our services. People are busy, they want to take shortcuts. Sometimes they want to talk, even though if they're not a official Spanish speaking representative to make the day go faster. We're taking shortcuts, and we shouldn't be doing those things. Having community health workers invested in helping us care for individuals can be a big asset. You see that as we go and try to make sure that we're providing vaccinations to our Camden community in Camden. Sometimes our communities are more likely to listen to some of the people that they deal with on a day-to-day basis, like clergy, like principals. We must make sure that we're including other healthcare providers and people who are looked up to in terms of authority in the community. And then some other things are consistency in care. We need to make sure that we have disparity awareness. So that's one of the goals of this talk today, is that you're aware of some of the disparity that exists, maybe not for your particular practice, but where do those disparities exist? If you're not looking for them, you might not know that they're there. So I challenge all of you to look at your practices, look at them by racial, ethnic background, and see where gaps in care may be existing. Some of the other things are obviously patient education, as they've learned in many of these bias studies. How you educate and how you talk to patients can have a great impact on their willingness to follow your instructions or to feel that they can trust you. So reflecting personally on your own personal interactions with patients can be very valuable. There is, practitioner bias. And so I hope that none of us at this point are afraid to recognize that we may have some of this, and hopefully we're all willing to work to identify those biases and overcome them. The last item here is training and recruitment of physicians and other healthcare practitioners from racial and ethnic groups. And this is something that I've spent a good amount of my career working to do, and hoping to convey that to others, and especially our department chairs as they are looking for physicians in their departments. And you may say that, well, this is difficult, because if we look at the percentage of active physicians currently, and this is from 2018, but it's the most up-to-date data available from the AAMC. Only 5% of our physicians are Black or African American, and only 5.8% are Hispanic. So that's not a large pool to pull from if we're trying to increase our underrepresented backgrounds. And those have been a particular focus to us at the medical school, given the demographics of the Camden community. So we need to work to get those numbers up. And people have been working at this for years, but because of many things, including bias, that number has remained relatively flat. So I want to just provide some support for increasing physician diversity. And there are many studies that have been done to this regard. Cooper is one of the individuals who's done a lot of work on this, specifically in race concordance. So looking at outcomes and patient satisfaction based on the race and of the patient and the race of the physician, and showing that when you have concordance of race, there's an increased length in the visit time, more in observed observations, more connection with the patient, listening and asking crucial things that are often missed in other encounters, perhaps because of uncomfortability or not having experience of working with patients in diverse backgrounds. So patient satisfaction scores definitely improved with race concordance. And the same goes for concordance with language. And what was also noticed in the language concordance studies, that there was also increase in treatment compliance. When the AAMC collects this data on physicians, they also collect on areas of service. And what has been shown time and time again is that physicians who do come from underrepresented backgrounds are more likely to be primary care practitioners, and they are more likely than their white counterparts to serve in medically underserved areas. And in a time where we have these great disparities, this is just more evidence to support that. I want to give a shout out to one of my friends and former colleagues, and one of your former colleagues, Dr. Faluso Fakarade, who is an interventional cardiologist who trained at Cooper. I've known him from his days at Rutgers and one of the pipeline programs there. And he's a prime example of how diversity in medicine can have an impact, and that he is currently now down serving in the Mississippi Delta, and his passion to make a difference in underserved communities has been nationally recognized now. And in just a 3-year period, he's been able to decrease the rate of amputations by 88% in that population, which I think is just amazing. I was talking to him earlier this week, and in October, he started working with Congressman Payne on an act, the Amputation Reduction and Compassion Act. And I'm told that today this act is actually being introduced. So this is just evidence of how somebody who's passionate about serving the underserved can really make an impact, not only in decreasing the rates of amputation, but pushing it further to help advocate and really make change at a national level. So we need more Falusos. And I'll bring that to now, just hopefully spending just the last few minutes just talking about our work at the medical school. And that's one of my goals, is to make more physicians like Faluso who are willing to give back, who are diverse in nature. And while we look to have a very diverse class in terms of not just race and ethnicity, but gender and certainly in LGBT status, all of those things, one of our focuses is trying to increase the number of Black and Latinx physicians in our country. And The way you make change is by making statements and by showing commitment. And I think that's one of the most impressive things that I've seen about the medical school in general, is that from the beginning, there was a commitment to diversity, to have a full-time person in that role, and to make sure that we are moving forward. Although I started as the only person working in my department, with the growing programs that we run, I now have these 8 individuals or 7 other individuals working with me on a regular basis to improve and enhance our diversity initiatives. So you can, if you have any questions about anything related to diversity that you want to get involved with, please reach out and contact any of us. We also have an Instagram page that we try to promote our events on. Dr. Weinstock mentioned the Pulse program. This is one of the programs that we've been running since the beginning of the medical school. In fact, our first Pulse program was before we even had medical students. And so it's been running for over 10 years now. We've had over 400 students in the program. Not all of them are going on to become physicians, but over about 30% of them have either completed medical school or are currently enrolled or will be matriculating next year. And that's something that we're very proud of. Close to 60 of them have come through Cooper. Not all underrepresented medicine, but many also financially or educationally disadvantaged. And many of the faculty at the hospital have been involved in helping us educate these students. Another program that we run is for high school students. It's a Saturday academy. And again, we're doing the same thing. The earlier that we can show students what the healthcare workforce is about, the more likely they are to have an interest in it and pursue it. So we can't just say that people aren't there, or not available to recruit as physicians. We have to take that initiative to inspire and to get these students to think about it. And this was one of the programs. These are some older pictures. We actually did this when the 10th floor pavilion was still space to have meetings and so forth. But this is where we ran that first high school program. We now do it at the medical school. With COVID, we've had to do it virtually. So I do want to give a little shout out to a couple of our cardiology friends, Phil Corin and Vika Sunder, who spent a Saturday morning with us last month talking for probably an hour or so each to 40 or so very interested high school students. And it's an amazing that something like this can really stimulate a curious mind. We know that we have to even go younger. If you're talking about sciences and interest in sciences, you really have to target that by the time the kids are in like 5th grade. And so we do also have a program where we do outreach to our elementary school children. And this is, a variety from our basic scientists to our administrators, to our clinicians, and of course, all of our medical students are involved in the Camden community. And that's through our service learning. It's again, speaks to the school's commitment to diversity and community. It's a part of our curriculum where all students do community service or service learning throughout their medical education. It's our way of making sure that they're aware of the social determinants of health. There's their opportunity to learn about people from different backgrounds. It's about their opportunity to understand what their biases are and to challenge them, to overcome them. They do this in a way that is, non-threatening. All of our students do the Harvard Implicit Association test as well. And so, they really understand how this impacts patients and how it can really make a difference when you're able to connect. At Cooper, I'm really proud to say that there have been a lot of changes that have happened within the past year. Being named as one of the senior advisor to the senior leadership, I think was an important step. They have also, for the first time, hired a vice president of diversity and talent acquisition. If you haven't met her, her name is Ardella Coleman. She's a wonderful woman and she's doing great work already. And Dr. John Porter was also named to have a diversity role and is helping with some of the physician rollout in terms of diversity initiatives. Now at the medical school, at the GME level, at our student level, and at the faculty and staff level at the hospital, there are 4 different diversity councils. And the reason for those councils is to help make change, to help bring diversity and equity and inclusion to the forefront. And that starts by listening to people. So I know Ms. Coleman has been going around and doing a lot of kind of these listening tours, hearing what people want, seeing how we can make this a more of an environment where people feel that they belong, that they feel that they are included. So identifying things that we can do for that. One of our focuses at the medical school is anti-racism education. We're working on how to build that into our curriculum, especially given all of what's going on in our country today. We feel like that is something that we definitely need to address. That spills over, not just, from the police in the community, but it spills over into our medical environment. It impacts our patients, and it impacts some of your coworkers who may be from those minoritized populations. We see this bubble up also happening amongst the Asian community, and we need to recognize that and to reach out and support our colleagues. We hope to do more cultural activities, again, that make people feel more included, that they're valued, that they come to work and it's a place where they enjoy being. Some of the things that we can do is make our environment more welcoming. Providing places for people to pray that need time to pray is certainly important. Having places where women can nurse, and if they're working away from their nursing babies, those things are important. Having images on our walls that represent the diverse communities that we serve can also help change our culture. And I know that each of our department chairs are actively working on diversity plans. If they haven't already begun to talk to you about that, I'm sure they will. Probably having me as part of this conversation today is a part of that plan, but really looking at how you can have an impact on the Cooper Health System. Your patients, your students, and your colleagues are all good steps in making a workable diversity plan. So I'll just end by saying, I think diversity and inclusion allows us the opportunity to take into account multiple perspectives in the delivery of care for our patient, and our service to our community, and in our medical education. So that kind of meshes nicely with to heal, to serve, to educate. And I love hashtags, so I say achieving equity through diversity and inclusion is the way to go. And at this point, I would be happy to take any questions if there are any. I'll stop sharing my screen.
First, I want to just thank you, Jocelyn, for an outstanding lecture, and more importantly, for all that you do every day and have done for 20 years for Cooper and for our health system and for the students to further the cause of diversity, equity, and inclusion, and make sure that we're all better educated. And you certainly achieved that goal today. This was fantastic. It's just amazing. So thank you so very much. And also thank you for taking time out from your personal day. I know it is your birthday today. We do have a few minutes if you're willing. We'll see if there's any questions.
Absolutely.
Yeah, I have a question, Perry. So I want to echo what Perry said, that absolutely superb talk. And thank you, for all your work in diversity at the medical school and at Cooper. And so I'm really thrilled that, we in the Division of Ed have you speaking here today. As you pointed out, that nice slide, that pie graph that you showed, that, the subspecialties are obviously greatly impacted on the pipeline, or the lack of diversity as we get down to cardiology in particular. And I'm just wondering, you pointed out so many different programs and things that are going on in committees, and I'm just wondering, could we do more, at Cooper, other things that the faculty, the just us, working out there in some more grassroots things. I think the high school stuff, the elementary schools, and at the medical school, we would like to obviously have our own goal of increasing diversity within cardiology, because we're doing so poorly now, not necessarily at Cooper, in general in the field. But is there something that we could do as just individuals, as faculty?
Well, I mean, I think, it's just that, like reaching out to the medical school and seeing where you can be of help, having two of your physicians come and talk to our minority students. You just never know who that stimulates to have a career in medicine. I know from personally, I came from a family, neither of my parents went to college. I was part of a program for engineering, and had I not been in that specific program, I would never have thought I would have a PhD in biomedical engineering. So it's because of a program like that somebody had a vested interest in me. And I've already, connected Dr. Corin to a medical student, a first-year medical student who thinks he wants to be a cardiologist. So making that connection and then being able to spend some time with that individual, and even if they don't go into cardiology, at least you had the opportunity to spend time and really nurture that career. And we can do more of that. Again, I think the younger age children are the ones that really can benefit, because if you don't see it, you don't think you can be it. So that's one push, to have more diversity in medicine. But even, going out into a setting where there are fifth graders there, them being able to do a practice intubation or use a stethoscope can have such an impact on a child who's never had the opportunity to have that in their hand.
Thank you.
Sure.
Are there other questions out there? Please speak up if you have a question. I have a quick question while people might be thinking, and that is, I'm thinking back to my medical school, and we had no courses on this. We learned nothing about this. This is all in the recent times. How do you think our medical students are doing, and what will, I'm sure we're measuring all this as we go forward, but since Cooper has devoted so much time to this, have you seen the benefits already in some of the graduating students? What are you finding?
Well, I do hear, back from some of our students. In fact, I was on a Zoom call with several of them this week, and many of them continue to stay involved in contributing. Their call with me this week was because they wanted to reach back and make sure that they were providing services for current students, but they continue to try to be involved in community service activities. And many of our underrepresented students are going on to fellowships. So the individuals that I had on the phone, one of them was getting ready to go into an addiction fellowship. One of them is a cardiology fellow, and one is in a pain management fellowship. So they're doing wonderful things, and spreading the word about what a great institution Cooper Medical School has been. So that helps our other students get ready to hopefully match in the future.
Outstanding work. I don't know if there's any other questions, but we're a little bit over time, so maybe we'll bring it to a close. Just let me again thank you on behalf of everybody in cardiology, and really everybody at Cooper, for all the work that you've done and for showing us the way. We really appreciate you taking time today to join us, and go enjoy the rest of your day. Have a happy birthday.
Thank you so much. It's my
Happy
pleasure.
birthday.
Thank you.